So with that, I would like to introduce our speaker. Dr. Denise Nebgen is a professor of general gynecology in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center. Her research centers on cancer prevention and quality of life for female genetic mutation carriers, cancer patients, and survivors. She's the director of the High-Risk Ovarian Cancer Surveillance Clinic at MD Anderson and is the co-principal investigator on numerous salpingectomy with delayed oophorectomy trials, including the International WISP-2 salpingectomy trial. She is a North American menopause practitioner, certified menopause specialist, and cares for survivors and previvors after cancer and/or risk-reducing surgery. I feel very lucky and very grateful that she is here to educate all of us today. So with that,
Hi, everyone. It's such a pleasure to be here. I'd really like to thank Force for inviting me, and I hope that I can share some of my, what I've learned over the years with taking care of people just like you. So that's why I'm here. And I happen to have some of the, or all of the worst menopausal symptoms in the book. So if it's not from experience with you guys, it's my own. Yeah, as she said, I'm a general gynecologist, so I'm able to both do the risk-reducing surgery. When I first got to Anderson, I thought, oh, this is great, you know, I can operate, take care of all of you. Then I quickly realized I was the one creating the early menopause and the premature menopause. So I'm now here. After a while, I learned that it's time to figure out how to fix it. So I have no disclosures. First things first, in order to know what it is, we need to go through some definitions. So natural menopause occurs at approximately age 51. There's a range anywhere from 45 to 55. So early menopause, by definition, is when it occurs age less than 45. And the prevalence of this is about 16%. And then premature menopause is when you go into menopause or your periods stop at age less than 40. So that's an entire decade earlier than natural menopause. And its prevalence is about 2%. This can happen spontaneously, or as many of you out there probably have experienced, due to surgery. The other name for premature menopause is premature ovarian insufficiency. It used to be called POF, or premature ovarian failure, but nobody wanted to be a failure. So the ovaries actually, when it's spontaneous, they actually do fail. They just stop working. So with that, let me briefly review, using this graphic, the stages of menopause. So on the left, you'll see the estrogen levels, and on the right, or the x-axis, is age. So our cycles start with puberty. And so, as many of you probably remember, either from yourself or if you have young daughters, when you first start having periods, they can be totally random. It usually starts between 12 and 14, and the cycles can be all over the place, and hormones can be all over the place. And then it balances out, and you have the normal reproductive stage of life when it's time to have babies. The next stage is perimenopause, which occurs between 35 and 45. Those numbers are a little bit young. I really think it's classically in the 40s. And this is a time when our estrogen and progesterone, our two main hormones, get out of balance. So we end up with high levels of estrogen and low levels of progesterone, which kind of wreaks havoc on our cycles. Instead of having every month long or monthly cycles, we start having every 3-week cycles, so they can be more frequent. And then they can also be very, very heavy. So flooding can occur with clotting. So this perimenopause is a transition to the cessation of menses. As time goes on, you can then start having skipped cycles and more of the classic vasomotor symptoms like hot flashes. Eventually, you'll get to the final menstrual period, or the last period, which is again at around age 51. Big, broad range, though. Then postmenopause is by definition 1 year after the final menstrual period. And during postmenopause, both the estrogen and progesterone levels are extremely low, and that's what causes most of the symptoms. So now that we've defined them, let's talk about what causes them. So the number one reason for most of you here is having to have risk-reducing surgery due to an elevated risk of ovarian cancer, as we've all been hearing about. Other things, anything that would lead to a surgery on or near the ovaries can disrupt, and women can go into, even having a hysterectomy occasionally, OB-GYNs out there will just take out the ovaries early when they really shouldn't. Nowadays, they should take out the fallopian tubes, called opportunistic self-injectomy, as we've heard, but many of them just go ahead and take everything. Other things like medical treatments, we all know can cause this. Many of you have had probably chemotherapy for breast cancer and can have gone into what we call classically chemopause. And it's called that because usually if the menstrual cycle is going to recur, it'll usually recur within the first year. Every once in a while, it'll recur in the second year. But it's important to use birth control during that time because your body can spit out an egg even though you're not having periods. So other things that can cause it are radiation, whole brain radiation, whole body radiation, or radiation directed towards or around the ovaries, such as when you get anal cancer treatment. And then a few lifestyle factors. Smokers can go into menopause a little bit early. So there are a bunch of signs and symptoms of menopause, and we're going to go through these. Remember, menopause is a natural part of life. It's inevitable for all of us. It's just when you go through it early due to surgery, often these symptoms are described as being far more intense. That's a little bit debatable, but many of you out there could probably vouch for this. So the first and probably the worst symptom, or the one that everybody knows, is hot flashes. These are happening because of the significant drop in estrogen levels. And they can happen to all women or no women. So for each individual person, they might get all of these symptoms, that would be me, or none of these symptoms. And it's really hard to figure out who's who. So night sweats are caused by a disruption in the thermoregulatory zone in the brain, or as my husband likes to say as he points to my head, yes, her thermostat is completely broken. So I had terrible night sweats, and finally they have just stopped. I'm very thankful. Mood changes can occur, but thank goodness I don't actually see a whole lot of this. They really happen more so during the perimenopausal transition. So for those of you who are optimists out there, if you go through early menopause because of surgery, think of it this way: at least you're skipping perimenopause. So I like to ask my patients if they've ever had a history of postpartum depression or major depressive disorder, because if you have, and you're planning risk-reducing surgery, you probably want to get back in touch with your psychiatrist or back onto the medication that worked, because it can happen again after surgical menopause. Sleep disturbance is a big one. We know that progesterone helps with sleep, and all of the hot flashes and night sweats disrupt sleep. But some women actually just say that they wake up at 3 o'clock and can't go back to sleep, or they lay down and they can't get to sleep. So this really wreaks havoc for the next day. Vaginal dryness is a big one, and we'll come back to this again. And all of these together can lead to sexual dysfunction. Unfortunately, as we just figured out, the sexual talk is next door, and they should have put them at different times. But so we can hit a little bit of the highlights. But sexual dysfunction is probably a little bit worse here. When you go through natural menopause, the estrogen and the progesterone levels both drop. But our ovaries make a low level of testosterone. It's about 1/10 of a man's level of testosterone. But when you have surgical menopause, all 3 levels drop, and hence some of the reason for sexual dysfunction. So now let's go through some of the physical changes. The number one that everyone hates is weight gain. This is caused by increase in insulin resistance along with a decreased metabolic rate. So many of my patients say, but doctor, I'm eating healthy, and I'm not eating any more than I used to, and I'm still working out. But the problem is, if you have a decreased metabolic rate, you now have to work out harder, a little longer, and eat a little less. Changes in libido, as we just said. Skin changes can include dry facial skin. Actually, I'll never forget watching my mom pluck the facial hairs in front of the mirror, and I just thought, oh my God, that's horrible. What are you doing? Until, of course, it started happening to me. So dry skin, coarse facial hairs, thinning hair, a lot of this. Bone density loss can occur already starting in perimenopause, and it can get significantly worse during menopause. For all comers, estrogen definitely supports bone health. Vaginal dryness. Dementia is something that's a little bit controversial. There are definitely some studies that show, increase in dementia, especially the earlier the menopause occurs, so with the premature menopause. However, there's also some studies that say it does not occur, but overall, we pretty much think that it does. Now, sarcopenia may be a new word for some of you. Who out there have heard of sarcopenia? A few. It just means loss of muscle mass and strength. This is what leads to frailty of the elderly. It starts in perimenopause, and you can lose half of your muscle mass after menopause. And it can go fairly rapidly. And so it's important to know that it occurs when you're not doing weight-bearing exercise, and it improves when you are doing weight-bearing exercise. So this means we all have to keep working out, lifting weights, staying healthy. So now let me talk a little bit about the long-term health risks of early menopause. Certainly we know that estrogen supports bone health, and without it, you can slowly but surely lead to osteopenia, which is low bone density, and then osteoporosis, which can increase fracture risk. We also know that the loss of estrogen before the age of 45 leads to a slight increased risk of cardiovascular disease about a decade or 2 later. So here you've survived no ovarian cancer, yet you're facing all of these other things. there's also an increased risk of overall mortality and diabetes. The good news is there's a decreased risk of breast cancer. So the important thing to know is that if you can take hormone replacement therapy, many of these long-term health risks will be reversed with hormone therapy. So those of you who can take it, it's strongly recommended to take it at least until the natural age of menopause, or 51. You can also take it for longer if you're symptomatic, but then it also becomes a little bit controversial. Certainly, the breast medical oncologists would much prefer if you've already had your double mastectomies prior to going on to hormones, but it's not mandatory. So now let's get into the treatment options. They're basically broken down into these three categories, and certainly hormonal is the most effective for treating the vasomotor symptoms and for reversing or at least decreasing those long-term health risks. But we're going to get into all of them. So what I like to ask my patients, I ask all of them the same questions. First, are you having hot flashes? If they say yes, which 80% do, give me a number from 0 to 10. So on a scale from 0 to 10, how bad or what is the worst intensity of the hot flash? Typically, they'll say 7 or 8. Some have said 12. Whatever it is, that's your baseline. And then, are they happening all day long, all night long, or just here and there? And then the same thing for the night sweats. A lot fewer people have night sweats, but it is very common. And then what's the intensity, and is it happening just at night, or are you also sweating during the day? And so we know that these are important because this is actually how you base the treatment using hormones to help them relieve the vasomotor symptoms. So I will typically prescribe not the highest dose for early menopause, but the second to the highest dose. I'll let them use it for a couple of months, bring them back, re-ask the questions, and if the questions are answered with getting significantly better, either gone is great, 0 is great, but if it's 0 to 3, most people can tolerate that. But if it's still extremely high intensity, then I go up on the hormone. If it's pretty much gone, I stick at that level, okay? Because what we want to do is actually taper over the next X number of years, however long it takes to get to menopause, the menopausal age, or beyond. So that's why I don't start at the lowest dose. You guys may have heard after the Women's Health Initiative, the recommendations start at the lowest effective dose and use for the shortest period of time. That does not apply to early menopause and premature menopause. You guys have lost, either those of you out there who have already gone through this or about to go through this, you've already lost your ovaries, many years before the natural age of menopause. So we want to use this truly as hormone replacement therapy, if we can. So as far as vasomotor symptoms, we know that it lasts for a mean age of 7.4 years. When I started, we used to quote that as 4 years. It's gotten worse. So, and 30% of people will have symptoms for over 10 years, and 10% can have them over the age of 70. Compounded bioidentical hormones are not recommended. I hate to break it to you, but they're not. Sometimes they can be used, but in general, we now have FDA-approved bioidentical hormones, and I'm going to show those in a minute. Those are what we should be using. And then on the same token, salivary and urine hormone testing is not really recommended. The little technique that I just taught you about the level of symptoms, we're supposed to titrate the hormone based on the level of symptoms. So most of what I'm going to talk about comes from the NAMS 2022 Hormone Position Statement. NAMS, as you've probably heard throughout this conference, is the North American Menopause Society. It's also now calling itself just the Menopause Society, but most of us know NAMS. So it's important to remember, if you've had a hysterectomy, you only need to take estrogen, which, based on studies and in theory, is safer. But if you have a uterus, you need to take combination estrogen plus progesterone. And again, as I just said, early menopause and premature, strongly recommended to take the hormone until the natural age of menopause. And hormone replacement therapy is actually FDA approved for 4 indications listed here. 1 is symptomatic vasomotor symptoms. 2 is the prevention of osteoporosis, not the treatment, but the prevention. So if you have osteopenia on your bone density and it's slowly getting worse, you want to have that hormone on board to help build bone. 3 is for the treatment of low estrogen states, such as caused by risk-reducing surgery. And then 4 is for vaginal dryness. So there are a huge number of benefits, I think you've heard me say, to hormone therapy. It reduces or reverses the bone density loss, the heart disease, and the cognitive decline. So if you can take them, you should. It is by far the most effective treatment for vasomotor symptoms, and it reduces the new onset of diabetes. We also know from a very good study that short-term use of hormone therapy in BRCA1 and 2 carriers after risk-reducing surgery did not increase breast cancer risk. This had a mean of about 7.6-year follow-up, so pretty good, not super long-term. There's also risks. Most of you probably have heard of this. Oral estrogen can increase clotting risk. So it can increase the risk of getting a DVT, deep venous thrombosis, which can go up to the lung, called a pulmonary embolus, and this can be deadly. So I say it just like that with all of my patients. But typically, we think that if you've taken a birth control pill or any type of hormone along the way when you were younger and for at least a year and haven't had any clotting, in theory, you won't have any, but that's not really proven. So the other thing that it increases is gallstones. I actually kind of forget this because I don't see it very often. So oral is the culprit. Transdermal, so patches or rings, they do not increase risk for DVT. Major contraindications include heart attack, having uncontrolled blood pressure, stroke, smoking, actively smoking, migraine with aura, or a history of having had a DVT and clots. And unfortunately, contraindicated in women who've had a history of breast cancer. And we can come back to this. So by far, oral is probably the most common, but we're trying to have transdermal overtake the oral users. Transdermal can be a patch that you stick on the lower abdomen or the buttocks, not on the breast, even if they're just reconstructed. It can be a vaginal ring. The ring can be for systemic treatment, or it can be just for vaginal treatment. And then gels. The gels you put on your arm, but you have to put it on and rub it in every day. So my patients are less fond of that, but it definitely works. And then progesterone-coated intrauterine devices can be used, and those, I'm sure you've heard, can last now up to 8 years, and this can be used along with, for example, an estrogen patch. And then pellets overall are not recommended. The reason is we learned this over 25 years ago When you put in pellets, they create sharp peaks and then troughs. So what you really want is steady state. So this is a list of the FDA-approved replacement therapy options. The ones that are highlighted in the yellow are bioidentical. What that means is that it's what our body makes. So 17-beta estradiol is what our body makes, and it's available as an oral formulation, or it's also in the patch. And then micronized progesterone, otherwise known as prometrium, is a oral formulation. Just for the record, there have been a lot of studies in Europe mostly where people who are taking these for other reasons and can't swallow, you can put prometrium or oral, the oral version of micronized progesterone in the vagina, and it works like a charm. So there's that. You learn something new every day, right? Other ones are conjugated equine estrogens. These are the ones that were typically in the Women's Health Initiative study, and then medroxyprogesterone acetate, which is a much stronger progesterone. There's a bunch of other combination pills that some of you might be on, or many practicing OB-GYNs out there like to use, but we like to stick with the bioidentical. So, as you've heard, the hormones are very effective. Now let's move into the non-hormonal prescription options for those of you out there with breast cancer. The problem is that many OB-GYNs in the community, they probably know a good bit about the hormonal options, but they may not know anything about these. And so sometimes you have to advocate for yourself and help with this. For hot flashes, probably the number one treatment is SSRIs. So SSRI is selective serotonin reuptake inhibitor. We know that the thermoregulatory zone is helped along by increased levels of serotonin, and so that's how these work. There's only one that's actually FDA approved, but there are quite a few that we use, and even though off-label, but very effective. These can decrease hot flash frequency and severity by as much as 75%. Gabapentin was actually developed as a epilepsy drug, and it's also used for neuropathy, so nerve pain. But if it's taken a couple of times a day throughout the day, it can help with hot flushes significantly. All of these have been studied in randomized controlled trials. The latest on the market is fezolinetant. I'm listing the trade name because you're going to see this all over the television on ads. It's Veoza is the trademark name. And I'm not going to go into the mechanism of action because it's even difficult for me to explain, but basically the thermoregulatory zone, they've been trying forever to figure out how it works and to figure out the receptors that, if blocked, can work on this, and that's what they've done. This is now FDA approved. However, it works wonderful. Has anybody taken it? Anybody out there? So of the patients that I've been able to get it approved for, it works like a charm. The problem is it is very expensive because it's a new medication, and you have to check liver function tests. The trick, though, is they have a coupon. So for women with commercial insurance, you can get this for $35 a month, but you have to get the coupon and go through the loops and hurdles. The other thing is, whenever a medication during clinical trials causes even a smidgen of an increase in any kind of normal factor, such as liver functions, they're going to keep studying that until they know how safe it is. So you have to get LFTs checked before and then every 3 months for 3 times to make sure they're stable. and for most people they are. These next two, oxybutynin and the clonidine patch, they're used for overactive bladder and hypertension. They actually have quite a few side effects, so I use them less likely. And then for night sweats, this is my hero of a medication, gabapentin. If it wasn't for gabapentin, I don't think I'd be on this planet anymore. I was miserable, and it completely knocked out my night sweats. So it works like a charm. The only downside to gabapentin is that in very, very few people, maybe 1 in 100, when you take it, you might have some sedation the first night or two when you wake up the next morning, but the sedentary effect usually wears off after 2 or 3 days. Some people have no sedation, most people have none. So it's okay to take during the day and at night, but I always tell people to start off by trying it over the weekend. So now let's switch into the non-pharmacologic treatments. So NAMS, in their 2023 position statement, actually analyzed all of these. They looked at all the studies and what's out there. So even though some of us have used these first three, cooling and exercise, they really don't work for hot flashes. Eating a healthy diet is very good for you, but it does nothing for hot flashes. We do know that excess BMI or excess body weight is associated with more intense and worsening hot flashes. And the flip side has also been proven that in a randomized controlled trial, that weight loss can definitely decrease vasomotor symptoms. So for those of you, if you can do it, there's another good reason to lose weight. So the mind-body techniques, cognitive behavioral therapy is definitely effective. You have to learn how to do it. It decreases the bother and the intensity of the hot flash. It doesn't necessarily decrease the hot flash, but it works. The other one that works is clinical hypnosis. Now this is a little bit unusual because the problem is you have to have a medical hypnotist who's obviously trained in this to do the hypnosis. Don't just let any hypnotist hypnotize you. That's my word of caution. So, and needless to say, these are few and far between. So if you happen to have access to one, you might want to try it. The rest have not been proven to be effective. NAMS actually looked at 25 different over-the-counter dietary supplements and basically concluded that absolutely none of them work. So save your money, don't try them. They did say that soy products, and they didn't necessarily go into which ones, but some of you can guess. They had some mixed evidence of benefit, but they didn't even recommend these, and no others were recommended. In terms of acupuncture-type treatments, at MD Anderson, we actually have an acupuncture, two acupuncturists, and I, in the midst of my rip-roaring hot flashes, tried it, and I promise you it worked. But according to NAMS, it's controversial. The one that they thought works probably the best is stellate ganglion blockade. However, you really need a pain doctor who's sticking needles into very delicate places, and there's probably more risk than benefit to this, and overall probably not used and not really recommended very often. So now I just want to go over some more of the more common things that happen during menopause for all comers, so we can try and get some help for this. In terms of sleep management, CBTI, cognitive behavioral therapy for insomnia, is proven effective. In other countries, you can get a prescription and go get trained on how to do CBTI. In our country, you can't. I don't think many places are available. You can get an app on your phone, so you might want to check that out. Sleep hygiene just means all of the loud and stimulating things that we normally do during the day. Please try to avoid those right before you go to bed. That includes screen time, computer time, exercise, caffeine, etc. Melatonin is safe. It could be tried. It's helpful for some. Gabapentin for sure works if night sweats are what's keeping you up. And then if you happen to be on a hormone replacement therapy that has a separate progesterone, like an estrogen patch and a prometrium or progesterone, take the progesterone at night. It definitely helps with sleep. Okay, vaginal dryness. Many people, and I think many OB-GYNs out there, think that if you give a person systemic or oral or transdermal estrogen or hormone replacement therapy, that it's going to knock out everything. The problem is that's not exactly true. For some women, the vaginal dryness can go completely away. However, for others, it doesn't, and it persists no matter what dose of systemic hormone you get. So then you need to give an actual vaginal product. So there's two things that you need. You need a moisturizer, which is something that helps increase the stretch of the vaginal mucosa, which is what estrogen used to do. And you need and you use this when you're not sexually active. You need to put it in at night and go to sleep. You need a slippery stuff, which is called a lubricant, and that's something you use with intercourse. So let me start with the non-hormonal products first. So in non-hormonal vaginal moisturizers, the best ones contain vaginal or hyaluronic acid, which is the same thing as the facial moisturizers, and many of these work very well. However, if you're a breast cancer survivor and you try this and it doesn't work, we often basically tell you that if you have a conversation with your breast medical oncologist, usually they'll allow vaginal estrogen, because there's a lot of studies that have looked at actual hormonal levels, and the systemic levels don't go up. Okay? So vaginal estrogen comes in tablets, creams, and ovules, and usually works very, very well. You can put a cream on the outside of the vulva and a tablet on the inside for the best results. Then there's some other moisturizers. I don't know if any of you have heard of these. DHEA, otherwise known as prasterone. And the trick with this is it's placed in the vagina nightly, and the cells convert it to estrogen and androgens inside the cells. It's called endocrinology. But because it actually does convert to estrogen, right now it's not recommended during or after a history of breast cancer. And the main reason is there's no studies. We actually do have some studies on estrogen use in breast cancer survivors, but we don't have much with the DHEA. Kind of the same thing goes for ospemifene. This is an actual orally taken SERM, selective estrogen receptor modulator, that stimulates the vaginal mucosal lining to thicken and improve. But it has some other side effects, and it's a SERM, and we have no studies in breast cancer survivors. So even though in theory it sounds like a good thing, it's not quite, we're not there yet. So I'll hold that in reserve. If all else fails and some of this is working but it's not fully working, you can try 4% topical lidocaine, which can definitely help with pain. So myself and a group of international providers got together and did a scoping review and created these international consensus recommendations for care after risk-reducing surgery for high-risk women. And in this paper, the main reason I bring it up, it does talk about all of these things that we've just alluded to. And if you have a provider that doesn't know the non-hormonal options, they can go to this paper, or let me back up and say, Martha Hickey, who is the final author. She actually published this table in her paper a couple of years ago. This table will give you all of the stepwise approaches to the non-hormonal management for vasomotor symptoms. It gives the names of the medications, the doses, how to escalate, the non-pharmacologic agents, and the treatment for vaginal dryness. It could be really helpful. This is how you could advocate for yourself. Hey doc, let's try some of these. As for bone health, as we said, when estrogen drops, so does bone density. There's a whole nother talk on this at the next session, but in a nutshell, I counsel all my patients that they need to be doing 4 things. The first, starting at the bottom, is if you've gone through early menopause because of surgical removal of the ovaries, you absolutely qualify to get a bone density test, otherwise known as a DEXA, within the first year after your ovaries are out. That is what you're going to be calling your baseline. Okay. Then if it's already showing, if it's normal, great. If it's already showing osteopenia or low bone density, you need to have it repeated within 1 to 2 years. It's usually a 2-year cycle. Bone density changes occur very slowly over time. But then I counsel everybody, with or without their DEXA results, to take calcium and vitamin D. You've probably heard this a lot. Calcium, you need to have 1,000 to 1,200 milligrams per day. Now, there's a little bit of concern of calcium deposition in the coronaries, so it's best if you get the calcium from your diet. So how do you know if you're getting calcium from your diet? I give my patients homework. I say, over the weekend, when you don't have an excuse because you're doing something else, pick up everything you eat, turn it around, look at the label, write down how much calcium is in it and how much you just took. After 1 to 2 days, you'll get a pretty good feel for how much calcium you normally get in your diet. I'm totally lactose intolerant, so I didn't get a lot of milk. So I've started using the Simply Lemonade brand OJ, calcium fortified orange juice. It's good. I own no stock. It's the way I get my calcium in my diet. So whatever the amount is you get in your diet, if you're absent like 600 milligrams, you need to take the horse pill, which means gummies, pill, Caltrate, whatever. And then vitamin D, you also need to have it checked at least 1 time. If it's low, they'll give you a high-dose vitamin D, and then you need to take it daily. And last but not least, you need weight-bearing exercise. This means anything on your feet. So standing on your feet, it includes jogging, running, walking, Stairmaster, jump rope, whatever. Even though cycling, for example, is great aerobic exercise, it doesn't count towards weight bearing. So you've got to be on your feet. It's 3 to 5 times a week for 30 minutes. It's a bunch. You also need 2 days a week of weightlifting exercises. It's because in order to maintain bone density, you've got to have strong muscles. Remember that thing about sarcopenia? You've got to do the weightlifting. So lots of homework for many of you. As for cardiovascular health, remember, early menopause can lead to slightly increased risk of cardiovascular disease. Unfortunately, cardiovascular disease is the leading cause of death in men and women worldwide, hands down, no matter what. BRCA1 and 2 carriers may be at higher risk if you've received radiation therapy for breast cancer or chemotherapy. We also know now that surgical menopause may further increase that cardiovascular risk. So the good news is, in a study of over 200,000 general population women who used hormone therapy until the age of 50, it reduced cardiovascular disease by a significant amount. So one of my take-home points is sedentary behavior and physical inactivity are the leading modifiable risk factors for cardiovascular disease worldwide. Cardioprotective effects of regular physical activity in the general population are clear and extend across all ages, sex, and race. So the U.S. Department of Health and Human Services recommends if you're going to do moderate aerobic exercise, that means walking or walking fast, you need 150 to 300 minutes a week. You need a bunch. If you're going to do what's called intense or vigorous aerobic exercise, you only need half that much, so 75 to 150. So if you're a jogger or a runner, you can kill two birds with one stone. You get your weight-bearing exercise and your aerobic all in the same. You want to minimize sitting down, keep exercising, eat a healthy diet, and decrease alcohol and smoking. So what's next? How do you get this all to happen? So remember, just to reiterate, if you have a history of depression or had postpartum depression, seek out that provider, get a prescription before your surgery. Or if it's already happened and you can't figure out why things are bad, it's probably because of this. You also want to find a menopause-informed provider. So if you haven't written down anything, this would be a good tip. There, as we mentioned, there are NAMS certified menopause providers. You can go to the NAMS website or just Google NAMS certified menopause provider. It provides a slot that you can fill in your zip code, and it'll spit out a list of between 30 and 50 mile radius of all of the people who are NAMS people. It's usually OB-GYNs, but it can be nurse practitioners and etc. who are NAMS members, and it'll list the ones that are NCMP or NAMS certified menopause providers. Try to find one of them. They should be able to help you. Everybody is jumping on the bandwagon, even Oprah. This is her latest magazine. It's actually pretty amazing. I was shocked at how good it is. She, of course, did not write the articles. She petitioned a bunch of the NAMS providers, and the articles are straight from the NAMS, well-respected, well-known providers. So it's interesting. It talks about perimenopause and menopause. This is a new book out as of April 2024. It's by Mary Claire Haver. She is the author of the Galveston Diet. Galveston Diet, not just because I'm from Texas, but has become very popular and very effective for those who I've talked to. I listened to this driving back and forth. It's a little slow, but it's definitely layman's terms, and it's pretty good. So, last but not least, I'm sure that some of you are going to or will want to ask about taking birth control pills after your risk-reducing surgery. So I've put a few factoids together here. As we saw, that study, short-term use of hormone therapy in BRCA1 and 2 carriers following risk-reducing surgery has not been associated with an increased risk of breast cancer. Now, combination oral contraceptives, in the general population, there have been multiple studies that also show women are not at increased risk of breast cancer. However, the risk of breast cancer for long-term users of combined oral contraceptives who go through early menopause are mixed. In a systematic review of 15 studies, they showed that 5 showed some risk and 10 showed no risk. So it's very important to understand one main concept here. So combined oral contraceptives are actually stronger than hormone replacement therapy. It's kind of counterintuitive, but it's true. So birth control pills are stronger. hormone replacement therapy is not as strong. So the studies on combined oral contraceptives that led to increased risk of breast cancer, if you're going to instead, after risk-reducing surgery, you're not going to get pregnant, you have already sterilized yourself. So you don't need a birth control pill. You can just go straight on to hormone replacement therapy. Does that make sense? Yeah. Yeah. So, and in theory, those doses are lower and therefore less likely to cause the breast cancer. However, there's no good studies on this. And I doubt there ever will be, or there might be, but we don't have them right now. And you don't need hormone levels to check during all of this, as we've said. So with that said and done, I'd be happy to take questions. And yes, I'm one of those NCMPs. In order to become one of those providers, you actually have to read this pretty thick book and take one of the hardest tests I think I've ever taken, and I have a bunch of degrees behind. And I tell you, it was tough. And after I passed my test, I was talking to one of the REIs in clinic, and she said, "Oh my God, I can't believe you just passed that test. I've been afraid to take it because it's so hard," and she's as sharp as a whistle. So, yeah, it's a good thing I didn't know that before taking the test. So, please come to the microphone.
The most pesky symptom I had,
Yeah, speak into it.
okay, how's that?
Good.
I'm going to whisper a little bit. Was the tingling electrical sensation in my fingers and toes. Can you speak to that? I didn't understand it very much.
As I said, I have almost every single symptom in the book. I had that too. There's a theory behind many of the symptoms, and it's all related to decrease in estrogen levels and increase in prostaglandin levels, also joint pains and things like that. The problem is there's no good fix except a tincture of time and if you can take hormone therapy. So, yeah.
Hi. Whoa, that is loud. I'm 54. I had my ovaries and my breasts done when I was 41, and I've been on estrogen because I was told that most of the time that estrogen alone was fine, but estrogen and progesterone increased your risk. But I also had my thyroid removed, and I've had severe sleep issues. I just looked up on NAMS, and the person I was seeing who told me to take compounded progesterone is actually a NAMS person, so I probably need to check in with her again, but because it sounds like that's not right. But progesterone helps me sleep so well comparatively to anything else, and I really don't want to take any sleep meds. I do acupuncture, yoga, weights, all of that stuff. I've tried gabapentin. I don't want to do SSRIs because they cause sexual dysfunction. So I guess I'm asking progesterone? I mean, is that okay or not?
So have you
okay?
had a hysterectomy?
Yep,
Yes,
hysterectomy
okay.
and bilateral mastectomy, yep.
Okay. So you might try just the prometrium.
Okay,
So the word progesterone, there's a bunch of different types of progesterone.
okay.
The one that is, as we say, bioidentical is prometrium, is its
Okay.
name brand, but it's called micronized progesterone. It's probably the safest. I can't advise you in terms of, but the bottom line is the fact that you've had your double mastectomy
Right.
and no history of breast cancer, you could take the progesterone.
Okay.
It shouldn't, in theory, there's minimal to no breast tissue left. And I don't think, remember the study that was done that showed increased recurrence was with all of these studies actually were done 2 decades ago, back when it was Prempro.
Okay.
During
and,
yeah.
And in combination with estrogen or alone? Or does-
I would take it in combination.
Okay, yeah, because just one last thing, because I do see someone, I live in Colorado, but I see MD Anderson for my oncologist, and they told me not to take anything. But I know part of that's probably liability and the fact that they're conservative on the oncologist side. So,
Right.
yeah,
So
okay.
we have the same problem. I mean, if you're a breast medical oncologist, you want to be advised and, tell people the safest thing. If you haven't had a history of breast cancer, and
I had stage 0 breast cancer from a prophylactic mastectomy in my left breast, so that makes it
so
kind of
DCIS,
Mhm.
something like that.
Yeah.
So DCIS, according to many of the MD Anderson Cancer Center's head of breast medical oncology says that if you have had DCIS only and a complete double mastectomy, you are safe to take estrogen.
Yay, thank you. That's very helpful.
Yay, good.
So I'm familiar with gabapentin
Get closer.
from surgery recovery.
Okay.
But haven't heard of it with the night sweats management. I guess what is the dosage that is usually recommended, and is there a short-term or long-term? Is there a time frame that's acceptable to take that for night sweats?
Yes. So for me, forever, so her question was, she's heard of gabapentin for other reasons. Remember, it's used for neuropathy of the elder, anybody who's had chemo and then has residual neuropathy. It's also used for nerve pain, slip discs and things like that. But it just happens to have this odd side effect that it helps with the night sweats. You usually start at 300 milligrams. You take it about an hour, if you can remember, before going to bed, and that usually will significantly reduce the night sweats. If it cuts them in half, you can increase it to 600 milligrams, or take 2 of the pills to see if it's better. And as far as we know, gabapentin is very safe. Again, its only minor problem is that in very few people it can have residual, make you feel sleepy when you wake up, but most patients it doesn't. So that's all. And you can probably take it for a long, long time, or until the night sweats stop. Yes.
I have 2. I had breast cancer when I was 33, had my ovaries removed and breasts, everything removed at that time, and unfortunately I have osteoporosis in my spine. So I have 2 questions. One is, your it says silicone or water-based lubes only. I'm wondering if it's like oil-based, but it's coconut oil, not some sort of like other kind of oil. Is that okay, or what's the?
Coconut oil is now the #1 used lubricant. It's very, very popular.
So
This doesn't list, you're right.
but it could be, as long as it's a natural oil, not like
It's fine, it's fine.
yucky oil. Okay. And the other one is, unfortunately, I have a severe spinal deformity, so I can't do normal weight-bearing weightlifting. So I've been going to the pool and like doing resistance in the pool, but I don't know if that's enough. Is there?
Probably not.
Yeah, well, when you said no biking, I was like,
So you don't have to have super heavy weights. I mean, literally 5-pound weights, 10-pound weights, that's all you need.
just for your arms?
Mm-hmm.
Okay.
You can Google a bunch of programs. They'll tell you stuff. But yeah, it doesn't have to be heavy weights. If you can get a little heavier, it's probably better. There's a lot of people who now are pushing for some. Has anyone heard of rucking? Yeah. Rucking? Yeah, Peter Attia groupies like me. Rucking is putting a heavy backpack on your back and going up and down hills and over the valley and through the woods. Yeah. In Houston, it's completely flat. So there are none. He lives in Austin, which is hilly. So, sure.
I'm in my infancy of looking at all of these hormones, so forgive me if this is not the best question, but you were talking about progesterone being less safe. if you don't have your uterus anymore, my doctor told me I didn't have to take progesterone,
You don't.
but then somebody was just asking about progesterone and sleep. So is there still benefits to it?
So the bottom line is, if you've had, so the whole reason progesterone is given along with estrogen progesterone therapy is when you have a uterus, the lining of the uterus, the endometrium, will overgrow without the progesterone. Estrogen will unopposed, as we call it, unopposed estrogen will make the endometrial thickness grow, which can lead to endometrial cancer. So for anyone out there who has a uterus and is going to take hormone replacement therapy, you have to have both. However, if you've had a hysterectomy, you don't have to take the progesterone. You just can take the estrogen, which is a little bit safer, we think. However, there's a whole bunch of other things that you can take to help with sleep. She simply has already figured out that when she takes progesterone at night, she sleeps much better. So she could use that as a sleeping aid. I wouldn't suggest that for everybody else. It's just she was asking that question.
Okay, thank you.
Sure.
Hi, I just want to encourage everybody about rucking. I just throw a backpack on with 2 5-pound weights in the back, and I take it out when I walk my dog every morning, and I just walk around flat, but I can already tell it's at least making me feel like I'm getting a better physical experience. So just a quick plug for rucking before I ask my question.
Awesome.
It's
Thank
really
you.
fun. And it's easy if you're already walking. I just really appreciate this presentation. I feel like there are a really large cohort of us who've gone through surgical menopause, early menopause, and are really trying to continue to find information. So just to our force kind of moderator here, continuing to have these types of presentations and kind of expanding that information, I think is really valuable. And then my question is, for the past kind of 10 years, I've been talking with a lot of different people around this, and I know a lot of folks who've either discussed or are trying small amounts of testosterone, and I'm wondering if you have anything to share on that in terms of helping with any of the symptoms that you've talked about today.
So in terms of most of the symptoms I've talked about, the answer is no, except for the one obvious, so sexual dysfunction. So there was a consensus statement put out through NAMS and all the other international sexual medicine societies about, I think it was 2019, and it basically states, and this is not about early menopause or about mutation carriers, it's just women in general. It basically says if you're having what's called hypoactive sexual desire disorder, which is a term that means you have to administer a questionnaire that says, prior to now, was your sexual activity satisfying? And they need to say yes. And then it asks a bunch of questions to clarify, has it happened because of marital dispute or, a reason that's fixable or that needs to be addressed first? And if it's all no's, then topical testosterone can be used to help with libido. The bottom line is, men, I apologize to all the men in the room, but men can get testosterone on every street corner, every physician, order through mail order magazine. I mean, you name it, you can get testosterone. There is no FDA approved, and there probably never will be, a female testosterone, FDA approved testosterone. It's complicated as to why that is, but I have now begun to believe it. What this position statement said is if you qualify for sexual dysfunction and want to try testosterone to help with that, you use a male product. Women make 1/10 of what a man makes, and you use 1/10 of the product that the man would use. So what that means is men can get it in for travel, instead of the big pump that they have, there's travel packets, and you take a travel packet and you use 1/7 of it, so you spread it out over like a week. Yeah, but should you use it? The next question is going to be, can I use it if I have a history of breast cancer? Even though there was one study that showed that it actually may decrease breast cancer risk, it is not recommended.
Okay. And then, I'm sorry, second quick question. So I had a BSO about 7 years ago, and I feel like the hormones that I was started on were lowest dose, most minimal, and I'm seeking kind of new care for that now. If I'm able to increase that, will I be able to kind of get any of that protective benefits back if I'm able to move up those levels for a period of time until I'm 51 or so?
That's a great question. Actually, it's a little bit counterintuitive, but they have shown that even the lowest dose is effective for bone health. So whether or not bumping up to a little bit higher will help, I'm not sure, because studies have shown that a low dose works. It's worth a shot. You could definitely, I wouldn't go sky high, especially if you've already been on it for 7 years, but if you're still under the age of 50, yes, you could definitely increase it and check a bone density before and after.
Thank you so much.
Sure.
Hi. Many of us are at higher risk, as you said, of heart issues from both early menopause and chemo. As we are getting older, what types of screening or monitoring should we be getting to hopefully identify those things before they get out of control?
Yeah, well, so you need a good internist to check, cardiac care. Most of the time you don't go straight to a cardiologist, but you could. They're going to check lipids and all of that. And then you certainly want to get a bone density test and follow with a bone advisor and endocrinologist if it's really low. So those are the main two.
Should we be more aggressive about things like cholesterol, knowing that history, than people without our background? I'm borderline. They're trying to decide whether
you're borderline.
Cholesterol-wise.
Okay.
Yeah.
Just for the record, Peter Attia is a physician out of, it just happens to be Austin, who is a longevity expert, and he truthfully probably has some really good information out there. Not that you should follow all of it, but according to him, all of us are way behind on the cardiac situation. We diagnose, or over, I think the number is 300,000 women per year die of cardiovascular disease annually. That is 7-fold higher than the number of women who die of breast cancer annually in this country. That's crazy. And so the fact that women have better cardiac status prior to menopause means nothing after menopause because it plummets. So anything and everything you can do to jump on the get better cardiovascular health, I'm all for it. Hence the bold red writing of, recommendations.
Thank you.
Sure.
I'm 56. I have BRCA1 pre-Viver, so I've never had cancer.
Excellent.
Had a complete hysterectomy, double mastectomy, and was terrified of menopause. I surveyed the population prior to having my my hysterectomy, and people scared the heck out of me. I got divorced because of menopause. I had to quit my job because of menopause. All these things.
Yeah.
So I had so I got a patch right away. And then went to a breast surgeon who said, you either need to stop using the patch or get a mastectomy. And I was so terrified of menopause that I went ahead and had the mastectomy. So that said, so I've been on hormones pretty much ever since.
Okay.
And the doctor that I'm seeing now says you can continue hormones as long as you want. I have women well into my 80s who are still on hormones. I also have a family history of osteoporosis, and did a bone density test prior to the hysterectomy when I was 43 and normal, and ended up, and I do weight-bearing exercises, I do yoga, Pilates, all that, and eat well, and I ended up with osteopenia. The doctor that I'm seeing, the OBGYN, said there's a medication called raloxifene, Evista, that they typically give to people who have osteoporosis, and it also prevents invasive breast cancer. And I said, considering my BRCA status, can I take it with osteopenia? And she gave it to me, and it's reversed the osteopenia, which is great. Or maybe the weight-bearing exercise has helped as well.
Right. All
So
of the above.
what's your opinion about that? And what's your opinion about staying on hormones forever and ever? Amen.
So I'll answer, the question is, how do I feel about raloxifene for treatment of osteoporosis? I'm not an osteoporosis person, but I've heard the exact same thing. It is beneficial, certainly protective for breast, and does help significantly with osteoporosis. But I'm going to just say, I think that sounds like a great idea. It's obviously working, but I'm not the expert on that one. The other one it could be a whole talk in and of itself, but I'll try to put it into a nutshell. So let's talk about a person who goes through at the normal age of menopause now for just a minute. So if a woman let's use me. So if a woman goes into menopause at age 50, the current recommendation is that she should, that right after menopause is the best time to start hormone replacement therapy. It's the window of opportunity in terms of reversing all of those downstream things. And it's recommended that you can take the hormone for up to about 10 years. Now, what that implies is that at age 60, or 10 years after initiating hormones, after the natural age of menopause, you should begin to wean off. Lately, there are quite a few members of NAMS and various organizations that say, however, if you are fairly healthy, still doing all the right things in terms of eating right, all of that, and still symptomatic, remember the 4 indications, symptomatic vasomotor symptoms, you can keep taking the hormone. So the reason all of this came about was that the Women's Health Initiative was done back 2.5 decades ago, stopped in 2002. I had just started private practice. I remember the day to a T. But what they did in the Women's Health Initiative is they gave people either Premarin, conjugated equine estrogen, or Prempro with the progesterone, randomized trial, but they gave it to all women, ages whatever, young, 50, all the way into the 80s. Even women who had never taken hormones for the first decade after they went through menopause. And they had an increased risk of stroke, heart attack, breast cancer, and clotting, DVT. And so the study was stopped. But retrospectively, afterwards, when they reanalyzed all the data, they found that a lot of that risk had to do with starting a woman after 10 years of never taking a hormone. So we don't do that anymore. We learned from it. It also shut down hormones for women for a whole decade and a half. But we're now more knowledgeable, and we now know this first beginning time frame as a window of opportunity where taking it is good. So, and we're less afraid of taking it past 60 because you've already been taking it the whole time. So there's no exact right answer. It's a decision between you and your practitioner and a risk-benefit ratio. Do the risks of DVT, et cetera, start increasing a little? It may, but so far so good. So it's a little bit tricky. And yes, there are people who are on it and will keep taking it forever, be it right or wrong. Yeah.
Hi, twist on a previous question. You had talked about starting the estrogen at the highest dose possible. And acknowledge that the fact that most of the medical industry is saying start at the lowest dose possible.
Let me stop you. I want you to
Please
finish that
clarify.
question, but remember that that recommendation start at the lowest effective dose for the shortest period of time is for women at natural menopause at age 50 going forward, because you're trying to decrease estrogen exposure and just get the amount that works, not for premature and early menopause. You guys have had ovaries taken out well before the natural age of menopause. So that's why we want to start at higher doses. Maybe not the highest, but higher doses.
So that might be the clarifying twist to my question. For people that feel like myself that have been in perimenopause well before the BSO, I think I started at 35 when I started having night sweats, and I had a BSO at about 43. Would your recommendation be to try to, again, twist on the previous question, start at a higher dose?
Yes.
Comparable to what my age should be?
Yes.
Or match where I currently am?
Go to a higher dose up until the age of 50.
Okay, thank you.
But again, remember, if the dose is a medium dose, many practitioners, whatever I say here is the way I do it. There are so many OB-GYNs out there, depending upon who you get, they have experience doing it their way, and it doesn't make it wrong. It may be very right, but whatever they do probably works for them. But you don't have to have the lowest dose. I'm not saying you have to have the highest. It's just that lowest effective dose doesn't apply to premature and early menopause. It should be a higher dose. Okay.
I wanted to follow up on the timing question. I heard other people, and I actually had the recommendation too before surgery to stop my hormones for a little while, I think because of the extent of the surgery. How is that stopping and starting in terms of safety and what age you are, how long you've been on? Like, I don't know what the data is on that.
So actually, the recommendation to stop prior to surgery has to do with because you're asleep and having a surgery, you have a slightly increased risk of DVT, blood clotting. And so because we know that estrogen replacement therapy also increases the risk of clotting, they're just trying to be safe and having it out of your system. So 1 or 2 stops due to surgeries is considered acceptable. It doesn't really do anything. You may start having hot flashes again, but yeah, it's not dangerous.
Hi, I'm sorry
Hi.
if any of these are repeat questions. I came in around the bone health.
Okay.
But I was curious, if you're not having issues with sleep, is there any benefit to taking progesterone replacement?
No.
Okay.
I'd say no.
And-
So again, I think she's the only person. I've had 2 people, so she's not alone. I have one other person who has the same effect. She happened to take her progesterone at night, sleeps like a rock. And that's why we say that. It does help with sleep. And so that other person needs the progesterone, though. But she said, I could give up everything else. I can't give up my progesterone. So it's kind of funny that for some people it's very profound. So, but no, if you don't have trouble with sleeping, you don't need the progesterone. So anybody who's had a hysterectomy, you don't need the progesterone.
Okay. My other question is around estrogen replacement. Specifically, I'm taking estradiol. I was curious, is there like an accepted max amount of replacement estradiol that's recommended?
Well, there's 1 milligram and 2 milligrams. Is this an oral?
I take a patch.
Patch. So the patches, the numbers, by the way, everyone, the numbers on the oral meds and the patches are different because it took me a long time, and I'm supposed to be the guru to figure this out. So hard to explain, but they are different. So the patch only goes up to, the highest dose, and you can use that. 0.01 or 0.1, yeah.
Yeah, I'm curious, so I was on a 0.05 milligrams a day and then went up to one by using 2 patches.
Okay.
And then recently upped it by another half a patch. So I'm just curious, my provider is NAM certified, so I have a lot of trust in her, but
Okay.
also just curious to get information here.
Well, again, remember, just if you're upping it because you're having horrendous symptoms, I guess you can justify that, but remember what estrogen does. And I don't know about, did you tell me about breast risk?
Yeah, I'm BRCA1, Previvor, and I've had a bilateral
Okay,
mastectomy.
you did tell me. So after bilateral mastectomies, I mean, in theory, you are okay. There's probably I don't know if I can think of a better way to do it, but there is a 0.1 patch, so you could switch to that and see if using just 1 patch happens to somehow be stronger instead of 2 of the 0.05, and it'd be less expensive. But probably I don't know if there's any harm to using too high of a dose. It's a good question.
Thanks. I have one other question. You mentioned coconut oil. What about for like lubricant? What about like a high quality olive oil? Is
Also
that-
very popular.
Okay, cool. Thank you.
Yeah, there was actually a paper out looking at a bunch of the different vaginal moisturizers and all of the different lubricants, and it basically showed that practically all of them work. I mean, you just have to use something. So, yeah.
Hi, this may be redundant, but it seems, I just want to get specific with your recommendation that for the general population, start at the lowest dose for estrogen. For those of us in surgical menopause, you're saying this doesn't apply, and that we can pursue a higher dosage. And because it's such a struggle to find a provider who is knowledgeable in practice with surgical menopause, I just want to get specific about having that dialogue with my provider. What can I use besides saying, I was at this conference and this woman said this? She's very qualified, and I can speak to all of your qualifications, but I'm sitting there in front of my provider saying, can I please do this? And they give me a deadpan look like, what? What resource can I bring in?
You
that
probably need to find a different provider.
Okay.
Sorry. Try that NAMS Google. Yeah. There may be one of those NAMS certified providers near you. That might help. Or just pick a different one.
Yeah, thank you.
Hi there.
Hi.
You kind of answered part of my question with just that previous, the previous person up here. My wife has had, she's a Previvor with the BRCA2. She had the bilateral mastectomy and the tubes and ovaries removed. And all of the medical professionals she's dealt with, and you've made it pretty clear this is an unpopular opinion, have said no HRT. Absolutely nothing, nada, because of scar tissue. It could attack the scar tissue and then result in reactivation of possibility of, not reactivation, but possibility of getting tumorous mass. It's pretty evident that this is not the leading theory based off of your presentation. So it sounds like your recommendation would be find other physicians for her.
Probably.
But then my next question was, this was 2 years ago that she had these surgeries, and you talked about in some of the studies that they did, if you had not had the hormones, like the elderly women when they were in their 60s, 70s, 80s, and then they just started them on hormones, it resulted in medical problems, blood clots. She has a history of blood clots. So now, being that she's been more than 2 years out, would that be something, even though she's 35, you would normally recommend start high, work low? With it being several years, would you recommend starting low and then coming up for that
So
reason?
does she have a history of a DVT, of a blood clot?
Yes.
Okay. So that alone is a contraindication to hormones,
Okay.
unfortunately. And that one I wouldn't override because it means she's susceptible to having another blood clot. And if you remember, I said, unfortunately, DVTs or blood clots in the lower extremity can go up to the lung and cause a pulmonary embolus, which can be very deadly. So that's the reason it's not recommended to go on to hormones. So what she needs is, so they might be withholding the hormone for that reason, but yet you're thinking it's just because of the recurrence. You might need to get her in for sure to a bone doctor, somebody who can check her bone density, do all of these things, get her into a cardiologist or a good internist.
Okay. Thank you.
Yeah, sure. Yes, yes.
Yeah.
Okay.
I probably have an impossible question, but I know we keep talking about risk, but the thing that gives me anxiety is I don't know exactly what the risk is. I know one is risky and the other one's riskier. Like estrogen alone has some risks, and then estrogen or progesterone could have more risks. But is there anything that quantifies that? Are there studies at all that tell you what those risks actually are?
Well, actually, so in theory, there has been data that showed that estrogen alone decreased breast cancer risk.
That's what I thought.
Yeah.
Okay.
So it's the breast medical oncology. I'm not bashing them. I'm just saying
Right.
I get it. Most or many breast medical oncologists don't just, because your risks with these mutations are so much higher, they're still very worried and trying to be as conservative as possible by not recommending estrogen replacement therapy.
Okay.
We,
Okay. And when you add progesterone, there's no quantifiable, there's no studies on that either, I'm assuming, because
so
it's
the
such a niche.
WHI was the main huge randomized controlled trial. It
Okay.
will never be redone.
Got it.
Because for many reasons, the company was Wyeth. It probably took a huge hit, and no company's probably ever going to take on any kind of a.
Okay, so being on estrogen alone for as long as I have been has not been that contraindicated based on my history. So
I couldn't really.
sorry. So being on estrogen alone for as long as I've been on, it was a good decision on my part. Like I tried to make an educated decision, so that makes me feel better. All right.
Okay.
Thank you.
Sure.
Hi.
Hi.
So I have the Mirena IUD that I got in less than about a year ago.
Okay.
And I'm considering getting the not the oophorectomy.
Okay.
So would it be recommended to keep it in?
Yes.
Okay.
Are you, so just for the record, I mean, probably most of you know this, for BRCA 1 and 2, about a decade ago, there was a study and then followed by another study that showed that there might be a slight risk of uterine cancer. However, when the second study was done and looked at, it really turns out that it's a very minuscule, not even realistic risk. So NCCN, National Comprehensive Cancer Center guidelines basically say hysterectomy is not recommended, is not needed, because you're not at increased risk of uterine cancer. So the straightforward surgery is tubes and ovaries. However, in the US, if you look at the data, probably 50% of high-risk mutation carriers do get hysterectomy. That's simply a decision between the doctor and the patient. So if you're going to not do a hysterectomy, I would definitely keep the Mirena. It's good for 8 years.
Right.
It'll provide complete endometrial protection for that time, and you can just do an estrogen.
Okay, great. Thank you.
Sure. Thank you, everybody.